So I'm really happy and pleased to introduce our second speaker of the day, Chris or Christopher. I'm not sure which one you prefer, Chris, but I'll go with Chris. There we go. Chris is a teacher of the blind and visually impaired living in New York City. He is the past president of the New York Association for Education and Rehabilitation of Blind and Visually Impaired People. And he serves on the board of the Deaf Blind International Network of the Americas Board. So Chris is going to be helping us to gain a better understanding of cortical visual impairments. CVI has a huge impact on our children's ability to interact with and communicate with family and carers and the world around them. In my personal experience, I found the diagnosis that my child was visually impaired incredibly difficult to come to terms with. And I worried so much about Jude and would he ever be able to communicate with us. But I have learned, and I'm sure Chris will reiterate, that with early intervention and diagnosis, the visual abilities of children with CVI can be improved. And so we're really excited to hear from Chris, who is a recognised expert in this field. Again, if you have any questions during the session, please just pop them on the chat and we can come to those at the end. So yes, welcome, Chris. Thank you.
Hi there, this is Chris. Thank you so much to Emma for the kind introduction, and thank you to Nuala for inviting me to participate. I've had the pleasure of collaborating with Nuala and some colleagues over the last few years, and I see Matthew there. Hi, very nice to meet the rest of you, and thank you to Christy for such an amazing and informative presentation. I'm just going to share my screen and share the sound. And I'm going to keep the chat box open as we go, because sometimes, we fly through so much information, and I know we have a limited amount of time. So if questions come up, just ask them as they come up, or if there's anything you want to clarify or comment on, just ask as they come up, and I'll kind of navigate between the chat box. I'm going to try to keep it to 45 minutes to make sure that we're on time and not getting too far behind. No matter how long you give me, I would have more content than time to share it in. So the goal today is just to get a good overview of CVI with a real functional emphasis on observing the unique behavioral characteristics. Also, just to get some shared foundational thinking around CVI for you as it applies to your children and your patients with SGS. So just a shared definition for everyone, when we talk about cortical visual impairment or CVI, we're talking about a neurological form of visual impairment as opposed to an ocular or eye-related form. Typically in kids with CVI, the eyes are functioning normally and healthy, and a child receives a clean bill of health from an ophthalmologist or an optometrist. But we're observing visual behaviors that are different and distinct and really can't be explained by anything else that's going on. Now, of course, unfortunately, often children with CVI who have any additional multiple disabilities or challenges, other sensory challenges and physical challenges, processing delays and whatnot, tend to get dismissed as it relates to their vision. And that is, the abnormal visual behaviors are somehow chalked up to just everything else that's going on. And that's the first really big piece that I want to emphasize. When you see observable atypical use of vision, there is something happening. And CVI is a very likely candidate in the case of SGS. So the vision coming in through the eyes is fine. What is a child with CVI seeing? Well, from an ocular perspective, they're really seeing everything that anyone else with typical ocular health is seeing. It's not the seeing part that is different. It's the processing or the understanding, the making sense of visual input that is different. We now understand CVI to be the leading cause of childhood visual impairment in places across the world that have access to quality neonatal health. And emphasizing that last piece because it's really kids who are surviving traumatic birth events, as well as kids who have significant seizure disorders and other early life experiences that have a neuro impact that have CVI. So we talked about how it's different from other non-brain related visual impairments. Just a little bit more for you on that note. If you have a child or a person with an ocular visual impairment, an eye-related visual impairment, you really just need to know what is the condition, the specific condition, for example, glaucoma or cataract or a retinopathy, a retinal detachment. If you know that the child or the individual has an ocular form of visual impairment, you know the distinct impact of that distinct condition, and you'll know the location of the eye that is impacted. You need to know the severity of the condition and also whether it's progressive or stable. And if you have all of that information, you can almost sort of guess what the impact is going to be on functional vision. And then we can see that through functional vision assessment. But it's going to be some combination of impact to acuity or detail vision, to a visual field loss, maybe tunnel vision in the case of retinitis pigmentosa or some other conditions, maybe ocular motor impairments or differences in the strength of the ocular muscles around the eye. So that could be observed as strabismus or amblyopia, as you see on the bottom left side. Children with CVI, we can't tell what's going on functionally by looking at the eyes alone. And in fact, we really don't have enough information from a neurology perspective about the visual processing center to get that information functionally from an MRI or a CAT scan or even a micro MRI or a live MRI. What we can get is associated risk factors. We can see parts of the brain that are different, but we can't look at that from a clinical perspective and get solid information about visual functioning. The questions often come up if there are any medical professionals or families who have been through all of these processes. What about a visually evoked potential, a VEP test? That's essentially a test that an ophthalmologist or neuro-ophthalmologist can do to look at whether the signal from the eyes is reaching the brain. And I've heard that described as that's like a lights on, lights off test. That can tell us it is effective in telling us information's getting to the brain, but it doesn't really tell us anything about how much or the quality of that information. And it certainly doesn't tell us what is the child understanding of that information that's coming through the brain. So we need to think in a completely different way when we look at CVI, and that's what we're really going to focus on getting a shared understanding of today. In order to suspect or diagnose CVI, you can see this is more of a functional diagnosis rather than a strictly clinical one. And that's why we often have trouble getting that diagnosis from clinicians. There has to be the alignment of these three criteria: a history of some sort of what I would call a neurological event. And in the case of SGS, I think that the most common cause of CVI is going to definitely be the impact of seizures. That's why we also see CVI, high rates of CVI in conditions like CDKL5 or Rett syndrome and some other chromosomal disorders and syndromes that involve some sort of neurological impact. There has to be a medical eye exam. So you still want to go to an ophthalmologist or an optometrist or a neuro-ophthalmologist because we want to have a clinical eye exam that shows us that what we're observing functionally, the presence of these unique visual characteristics we're going to cover, cannot explain the abnormal use of vision. Okay, so the medical eye exam can't explain that. There's a whole long list. This is just a short list of medical history significant for CVI. So you can see with SGS, it's definitely probably mostly going to come up in seizure disorders and impact of seizures. But there are a whole host of other different causes of CVI. And in terms of the impact on the brain and the location, that can vary a bit too, because the visual processing center covers a large area of the brain and several areas of the brain. So there can be damage or differences or differences in the structural formation of different parts of the brain, but especially back in the visual cortex and in the optic radiations. Frequently asked questions, I have a bunch of them, and I'm going to share with you a fact sheet as well with some answers to more. The most common one that I get is this from families and from professionals. The clinical eye reports came back normal or unable to test, but I know that the child's visual functioning is not typical. The first thing I would say is if you ever receive a clinical evaluation or assessment where the result says unable to test, all that means is that you're going to the wrong doctor. Unable to test means I don't know the alternative formats of testing something or getting you functional or quality information based on the standardized tools that I'm using. And we all know that our children and our students or our clients or patients are often it's not appropriate to use standardized tests that involve language or involve a whole variety of other standardized measures. Yeah, it looks like a familiar report, right? So I think this is a very common one that I get. Never accept unable to test. That means find someone else. But if you get this related to the eye report, the first question you want to ask yourself is, does this clinical vision specialist, whatever their role is, do they recognize or diagnose CVI? And don't assume that they all do. Even a really great ophthalmologist who really is an expert in their field, their expertise is really in the structure of the eyes and ocular vision. It's not necessarily in neurological visual processing. And as we've seen, the diagnostic criteria are fairly functional. They're not really clinical. And a lot of clinicians and ophthalmologists in particular may have difficulty or hesitancy making a functional diagnosis when really their expertise in their field is in making strict clinical diagnoses based on clinical tests. So if not, go to a low vision specialist who does, a pediatric low vision specialist who recognizes CVI and is willing to diagnose it. So, and I always recommend to families, ask that question before you even show up to the appointment. Ask that question on the phone or in your contact to make the appointment. Otherwise, you may be wasting your time and subjecting yourself to, yet another, negative report or not meaningful report that's not child-centered. That may be a neuro-ophthalmologist. A neuro-ophthalmologist is an ophthalmologist who has additional neurology expertise and credentials. And but again, don't assume that all neuro-ophthalmologists will diagnose CVI either, because often neuro-ophthalmologists are more accustomed to diagnosing conditions like dyslexia and other visual processing disorders that are often treated as learning disabilities rather than visual impairments. And then very importantly, follow up whatever clinical assessment you're doing to get the diagnosis with functional vision assessment. And I'm going to introduce you to a method for that. The clinical report is not going to get you a lot other than the diagnosis and maybe some neuro information about location in the brain, severity of impact. Severity of impact in the brain and location doesn't correlate directly to functional implications. And we haven't really found strong trends between what we see visually and functionally versus what we see from, say, a really good MRI. So on to the functional stuff. Why is it so important to identify and assess? Because unlike ocular forms of visual impairment, eye-related forms, with CVI, we actually expect to see improvement in vision, improvement in visual functioning, if we're doing the right thing to support intervention. And if you think about it, if someone has an ocular visual impairment, we're not working with those kids to improve their vision. Instead, we're working to teach them compensatory strategies to compensate for the fact that they have a visual impairment and still succeed in the world and access information, education, and communication, regardless of the fact they have a visual impairment. But with CVI, it's different. We're actually expecting improvement in vision. So that's a really exciting thing and something that I like to, it feels great to be able to tell families that if we can find out more about your child's visual functioning, then we can implement a set of simple interventions, functional interventions to support their increased use of vision, which is actually going to make a neurological impact on improving their visual functioning. Now, the one little disclaimer I should give to that is if you have a child who has uncontrolled seizure disorder that has a potential for causing additional damage, that could be one little hang up in that continuous expectation for progress. We should still see progress, but you may see like a regression after a severe seizure, but you should be able to once again pick that right back up and keep making progress going forward. It just looks a little bit different with an uncontrolled seizure disorder, but still expect progress and still work on interventions with the goal of progress. It needs to be based on assessment, and that's because we use different approaches to intervention depending on where the child falls on this range or scale or spectrum of visual functioning. Intervention has to be a team effort. I think I'm probably preaching to the choir here, but the way I like to explain it to professionals is that we cannot make neurological progress in a 30-minute, twice-a-week session with a vision educator. That's still an important session, but we need more than just 2 times 30 minutes a week, or 3 times 30, or even 5 times 30. We need interventions to be integrated meaningfully throughout this child's day. So we need everyone to get on board and understand this process and this approach. I'm going to share with you, I'll throw it in the chat box towards the end here, a link to a fact sheet, which provides all this information, a lot of what I'm sharing with you today, and also has on page 2, has some answers to frequently asked questions and some links to additional resources. So that's just a little fact sheet that I made up, mostly so I don't have to type the same answer to the same questions over email. I want to get into characteristics. I'm going to do a little crash course on CVI characteristics. But first, I think it's really important to have a basic understanding of what's going on in the brain that's different in visual processing to start to think about what we're observing in our children. In your visual processing center of your brain, the back of your brain, your visual cortex, you have 2 streams of visual processing. And you can think of these streams as like roads or highways through which visual information is made sense of. Information comes in through the eyes, it crosses back into your brain through your optic radiations, and then it's instantaneously made sense of in your visual processing center. What we take for granted as people who have neurotypical vision is that we have these 2 streams and they actually fulfill separate functions. In neurotypical vision, these functions are integrated. They're working together all the time. And, we don't realize that they have 2 separate functions and that they're even there at all. They just happen naturally. But in reality, they do have 2 separate functions. And for children and individuals with CVI, these streams are not working well together. They're not integrated together. And one of them is developing earlier or sooner than the other. So let's just understand this quickly. The dorsal stream is the visual processing stream or highway through which we get information about roughly where things are and the fact that there's stuff around us in our environment, but not what it is that we're seeing. And the dorsal stream gives you lots of information about movement, the rough form or shape of things, but not the detail of them, not the little detailed components of them. The dorsal stream gives us information about lighting, whether it's dim or bright lighting, and really nothing about acuity or detail, very blurry in that sense. The ventral stream, on the other hand, gives us information about what we're looking at. And we're using our ventral stream when we make what's called eye-to-object contact. Eye-to-object contact is directly looking at something. And if you can see my video right now, I've got my water bottle here. If I am using eye-to-object contact, I'm using my central vision to fixate directly on this object, and I can tell all the little details about it. If I'm using my dorsal stream, which is roughly associated now with like my peripheral vision, my side vision, everything except my central vision, then I really don't get that detailed information, but I still do see that something is there. and I can see if it's moving. I can see its rough form, and I can see if there's any colors or any anything that pops out there. So if that seems a little abstract, if you can see my video right now, I'm going to give you a quick little simulation of dorsal ventral vision. Holding up a mug with some pens in it. And let me know if you can't see my video, but I'm holding up a mug with some pens in it. And what you can tell is that the pens here are not any bright colors. They're kind of gray tones, white, black, gray. And there's nothing bright or that really pops out here. Now I'm holding it up about 3-4 inches from my right eye, and I'm not looking at it. I'm looking straight ahead. So it's in my right peripheral vision. I can still see that there's something there. My dorsal stream is giving me that good information about sort of there's an object here, a rough shape. This area here where the pens are seems very blurry. I can't really tell what's going on there. And if I wanted to, if you asked me to reach out and take one specific pen, let's say you want me to take this pen right here from that array, without looking at it, it's very hard for me to tell, and I'm going to reach and kind of probably get the wrong one, right? So that's a rough idea of what's happening in my dorsal stream if I'm looking at a very busy, complex array and there's lots of stuff there and there's nothing that really stands out. So what could I do if I'm not going to make eye to object contact and reach right for it? If I'm not able to do that, what could I do to better access this busy target? Well, one thing I could do is I could actually take away the other complex items in that target, in that array. So I took away all the other pens. Now let's see if I can get that one pen without looking at it directly using just my dorsal stream. I can get it no problem, right? But the world doesn't always work that way. We can't always remove all of the busy background and have a completely clean environment where there's nothing complex that makes it difficult for us to access things in our dorsal stream. So if I can't adapt the environment, instead what I'm going to do is adapt the target itself. So instead of asking me to get this, white or clear pen in an array of white or clear pens, I'm instead going to get this bright yellow highlighter. So let's see if same thing, I can reach and get that bright yellow highlighter without looking directly at it in this busy array. I got it, no problem. That's because my dorsal stream, my peripheral vision of my dorsal stream gave me really good information about this bright color. Some other things I could do is I could add some movement. Let's say if this pen was moving back and forth a little bit while it was in there, maybe I could get it. Another one I could try is to shine a light on that object. And now it really pops out in my dorsal stream as well. Okay, so that's sort of an intro, very quick little intro to what we're going to talk about next related to the characteristics of TVI. So I wanted to share, Nuala sent me some videos, and I wish we had time to go through all of these and really look at them. But I wanted to share just this quick, just a few, 10, 20 seconds of this quick little video of her beautiful daughter, Ophelia. And you can see this concept of direct fixation, eye to object contact versus this sort of what I would call a visual regard. A visual regard is as opposed to an eye to object contact. Visual regard is when you're kind of looking almost through or past something. There's clearly a looking happening, but it's not an eye to object contact. And when there isn't an eye to object contact, that means that the ventral stream is not fully integrated. We're getting some information in the dorsal stream. We want to think about what kind of information she might be getting when she's giving a direct look versus when she's giving more of a regard, in which case she's really activating her dorsal stream, getting information about movement, color, but not a lot about detail. So let's just watch and just, I want to get really in the habit, everyone in the habit of paying super close attention to visual behaviors. When is she looking? When is she not looking? What does looking look like? And then what are the objects in the environment around her that are contributing to whether she can look directly, indirectly, or not look at all? So I'm just going to show you a couple, 15, 20 seconds of that. Okay, and we could keep going from here, and you could do this with your own child. Video is super helpful, right? When you're able to look through a video as opposed to in person, we could really even pause in individual little places, and we could say, when is she not looking at all, and what's happening? When is she looking, but it's an indirect look, like there we go, right? That's an indirect look. And kind of shifts back and forth a little bit between an indirect look, something that approaches a direct look, and what's happening here, right? This is a relatively complex array here. You have spotted black and white things, not a bright color there, but there's some good movement happening there. And also her own sensory environment is pretty comfortable there. So this is going to make sense, and we can think back on this video as we look through some of these characteristics as well. And I'm going to share with you some other videos in a little bit as well. So we're going to do sort of a crash course in these 10 unique visual characteristics of CVI. This is just the list of them. We're going to go through these. As we walk through these characteristics pretty quickly, we could make this a 2-hour session if we wanted to, but I want to give you just the overview. When we walk through each characteristic, what we're thinking about is, how does this visual behavior, this unique visual behavioral characteristic, impact the child's visual functioning, their ability to use their vision to access information throughout the day? And what we're noting is that the same characteristics affect the child's vision differently as the child improves along this range of visual functioning. The range is the phases of CVI. There are 3 phases of CVI that describe the severity or the level of impact that these characteristics have on visual functioning. So it's roughly a scale of 0 to 10, and this is not an exact science, but this is a measurement system that we can use to sort of get a baseline of visual functioning and then track progress over time. And there is reliability data on using this tool. So especially, for somebody who has training and has some sort of established reliability in using it. The first phase, phase 1, sort of the most severe impact on visual functioning, is roughly 0 to 3 on the range. Phase 2, sort of moderate, is 3 to 7, and phase 3 is 7 to 10. Disclaimer here is that there's no such thing as 0. There is never a child with CVI who has 0 on the CVI range, because there's always some visual functioning, and it may be so slight and so limited and so specific, but that's still something, and that's still a place to start intervention. And I think that's what's most encouraging, is to just find, what is that little bit of vision? What's that little bit of vision that you're seeing, and how can you use that as a starting point to have high expectations for where this is going to go in terms of improvement over time? Okay. And also, there's no such thing as 10, because you never completely can resolve CVI, but you can get right up there, very close to, very near typical to visual functioning. Yeah, and Emma, I could not agree more. This broad sweeping diagnosis of blind is not helpful. It's distressing, and really, it's an inappropriate term to use for a child with CVI. A child with CVI is not blind and does not have cortical blindness. They have low vision, and they have a visual processing difference that's impacting their ability to make sense of the information that's coming in through their eyes. So I would always dissuade folks from using the word blind. You can use visual impairment, or you can use low vision, but a child with CVI is never totally blind. Okay, unless they have some other severe ocular visual impairment, in which case CVI wouldn't even really be discussed anyway. CVI, the phase, is determined by assessment using the CVI range, which I'll mention a little bit after we talk about characteristics. And again, intervention has to be guided by phase. We're using totally different approaches to a child who is in phase 1, as opposed to a child who's in phase 2 or phase 3. And our goal is always to move them forward and up through the range. with the highest level of expectation. And I have absolutely seen kids in early phase 1 progress through phase 1 into phase 2 and into phase 3 over time. You should expect progress no matter what the age of the child is or the extent of their additional challenges. Vision has nothing to do with cognition at all. And so even discussing that a child with additional cognitive or intellectual or developmental delays should somehow be treated differently in their vision, that itself is inappropriate and irrelevant. So we should have high expectations for kids with CVI across the board. Okay, so I'm going to do, this truly will be a little crash course in unique visual characteristics. So let's see how we do here. The first characteristic is color preferences. Now, what we saw with the dorsal ventral stream simulation, and just thinking about that, is that in your dorsal stream, it's much easier to see bright and saturated colors. I'm holding up this red glow stick in my right visual field. Even if I'm not looking at it, I can really see that bright red color pop out. So kids with CVI tend to have an easier time seeing bright, saturated colors. On the lower side of visual functioning, they may only be able to look at things that are a solid single color, a solid colored object, and maybe even a specific color, usually red or yellow, sometimes neons. So it's important to find out what are those color preferences. And as the child grows and improves their vision over time, they'll be able to look at objects of all different colors, but they'll benefit from the use of color to enhance their visual attending or to provide an anchor to what they're looking at. And in the case of this image on the top right side, this is an actual adaptation that we made in a classroom for a child with CVI who was really having trouble orienting in the room and would get very overwhelmed and overstimulated by the amount of things going on. And in order to help him orient towards where the classroom door was and kind of get his grounding and know how to find the classroom door, we didn't have to make the whole door red. That would be sort of overkill in adapting. Instead, we took a little red electrical tape and we outlined the light switch to the left of the door. And so this serves almost like a fire exit sign in a movie theater or in a building. We have this bright, illuminated, colorful target that helps us orient our vision when we're otherwise overstimulated or having difficulty orienting. Okay, so that's a little further up the range. Second characteristic is a need for or attraction to movement. Kids with CVI may only look at things that have movement or reflective properties. And then further along down the line, they may not need movement at near, but they may benefit from movement at a distance to orient their vision. Someone waving to them, waving hi to them a few feet away before initiating saying hi may allow the child to shift and look over at that person, just adding a little movement. The next characteristic is visual latency, an actual visual processing delay. And so I'm holding up my red glow stick in my right visual field. A child may not see that it's there, even its bright color, even if it's moving, even if it's close and in their visual field. And there's a little delay, and then you may see that orientation. So always assume that if a child is not looking at something, it may just be that they need a little more time to look at it without additional verbal, auditory, or physical prompting. A little more time to process. So we can keep track of that time. And then as the child progresses, we're going to see that visual latency decrease, or we're going to see that the child only has latency when they're overstimulated, tired, hungry, upset, or post-seizure. Next characteristic is visual field preferences. And we saw with the dorsal ventral stream, the dorsal stream is roughly associated with the peripheral visual fields. So earlier on the CVI range, the lower end of visual functioning, we may see a child have a very strong visual field preference, like they only look at things presented in their right field. Then as they make progress, we maybe have right and left, then we have upper, then center, and finally it's that lower visual field that tends to be difficult for kids with CVI well on into phase 3 and on into their progress. So that has a real impact on the presentation of materials, right? And we're going to have to be thoughtful about where we present things in preferred visual fields versus in difficult visual fields. It's why probably the easiest educational accommodation to recommend for a child with CVI is a slant board, presenting things up at an angle rather than flat on the desk in their difficult lower visual field. Okay, same thing with tray tables on adaptive chairs and whatnot. Okay, now the next characteristic is difficulty with visual complexity. And here's where I want to give a little breakout, because this is, no pun intended, the most complex characteristic to understand. And I think this is the one that really has the most overarching impact on visual functioning. We can think of the whole world as sort of like a, if you remember it from the US, we call it Where's Waldo. I think the UK guys call it Where's Wally, right? Remember these books where you're supposed to find this little guy in the striped red shirt? The whole world is like this incredibly complex array of information. And for kids with CVI, it's very difficult to make sense of where is that thing that I'm supposed to be looking at. It's not that they don't see anything. They actually see all of this, but it's very difficult to make sense of. It's overstimulating, and it leads to eventually a visual shutdown. And that's what we see as sort of this like staring off or this visual inattention. It's because the world is overstimulating. Now, we can do a variety of things to address visual complexity depending on where the child is on this range of visual functioning. Some children may just need a very light adaptation using a bright color to outline the visual target that is being sought out in the complex background. But for a lot of kids, that's not going to be enough. Just that little red outline is not enough, and we need to do more. We need to block off the busy array. Okay, so we need to find the balance, and where is your child in this sort of sequence of being able to deal with complexity? And those are just a few of the ways that we might adapt complexity. Now, that type of complexity we just looked at is what's referred to as complexity of the array. And that can be of two-dimensional targets, like in a book or a photo, or it can also be three-dimensional objects. We see this basket full of stuffed animals, full of stuffed toys. And in the basket, the toys are all overlapping and they create a very complex array. And it would be really hard for the child with CVI to be able to look at that busy array and be able to pick out an individual target or an individual toy. Whereas if we take it out of its complex background and we put it against a simple, clean background where it really pops out, especially a contrasting one where the color pops out against the background color, we're going to have a whole different ability to visually attend. So we want to be really thoughtful of that array. That's what we did with the mug initially. We took the pens out of the mug to reduce the complexity of the array. And it was much easier to access in your dorsal stream. This is just another idea for looking at sort of a sequence of assessing complexity of array. There's a link to this if you can want to read like a whole kind of article about this that I'm happy to share with you. But just looking at, you know, sort of targets against simple backgrounds, more complex backgrounds, even more complex backgrounds, and finally, super complex, almost camouflage backgrounds. So we want to find out where on this sequence is your child in their ability to deal with complexity of array. Okay. There's also complexity of targets. Targets or objects themselves have various levels of complexity. And when you look at these four images, you can see pretty well that there's also a sequence, a rough sequence you can figure out in the complexity of targets. So again, we want to know, where does your child fall on their ability to look at and visually interact or engage, even briefly, even with just a regard or a rough glance, towards the complexity of individual objects. Faces are incredibly complex, and children with CVI may have difficulty looking at faces or orienting towards faces. The reason for that is that complexity of faces overlaps with another characteristic, which we're going to talk about quickly and in a minute, about difficulty with visual novelty. It's easier for kids with CVI to look at things that are more familiar to them, including faces. So what we're going to see in the earlier part of visual development is no looking at faces whatsoever. And as the child makes progress, we're going to start to see some orienting towards faces, but not looking at them directly. And those will be the most familiar people. Okay, usually primary caregivers or somebody that the child sees all the time. Then eventually that's going to start to extend to eye contact and to starting to look at or regard unfamiliar faces. Okay. Faces themselves have a whole broad range of complexity. And perhaps for a lot of your kids, the most impactful characteristic is complexity of the sensory environment. Kids who have low muscle tone or high muscle tone, kids who have other internal stuff going on, there's a whole host of external and internal sensory input. The external input includes things like environmental context, even the temperature in the room or the lighting in the room. Trunk support and positioning has a huge impact on ability for a child with CVI to use their vision. And you may see a whole different kid in a more stable and comfortable position. There also is internal sensory complexity to think about, and that maybe we have a less control over. That's, whether the child is tired, hungry, in pain, feeling the impact of medication that makes them drowsy. Well, for kids who don't have CVI, all of these things may impact their just basic attention, but it's not going to impact their actual visual processing. And that's what's unique about CVI. Each of these things may have an adverse impact on visual processing. One of the most common misconceptions I get about CVI and that you may have heard is that the child's vision is constantly fluctuating. Yesterday, it seemed great. Why isn't it good today? It was fine this morning. What happened in the afternoon? It's not the child's vision that is fluctuating. It's the complexity of the environment that's constantly fluctuating, and the child's visual processing is just adjusting to the various input that's changing around them and within them. Okay, so that's something to also just think about too. What is causing that? You can see, and if we have more time, I could share a bunch more video with you too, but you can see this sort of, looking away. You can see this sort of, the same sort of characteristic of almost like a visual disengagement. It's not that the child's not seeing something. It's that they're having an easier time focusing on those other complexities, the other multisensory information, the difficult task of reaching, the difficult task of listening or taking a step. And they need to almost turn their vision off to regulate that sensory input. Okay. I think we have like a few more minutes. So I'm going to try to wrap it up relatively quickly, but I'm going to just kind of flash through some of these ones. Need for light or attraction to light. We used to call this light gazing because kids who are on the earlier side of visual functioning with CVI will often compulsively stare at lights, ceiling lights, windows, and so on. Wherever you are in the world, you probably in your schools have these terrible fluorescent panel lighting that we have in all of our schools around the US. For kids who are in Rifton chairs or adaptive seating, who have low muscle tone in their neck and require being sitting at an angle, like a 75-degree angle, so that they have neck stability, that actually can contribute to this light gazing, right? Because what are you looking at all day if you're tilted back at this angle in your chair? You're looking at these big, giant, terrible fluorescent ceiling panel lights. Cool, and I'm gonna go just another 5 minutes, I think, which is great. Allow me to kind of finish this little. So now we call this characteristic not just light gazing, but we call it need for or attraction to light. Because what we've learned over time is that it's not just about light gazing. A child with CVI, as they make progress in their visual functioning, may not do light gazing anymore, or maybe only will do light gazing when they're tired, stressed, overstimulated, or post-seizure, but they still benefit from the use of light to enhance their attending. Things like working against a light box or a backlit surface, or illuminating a visual target in order to make it easier to see, illuminating it with a flashlight. I think we found with a lot of our kids that on an ongoing basis, having a flashlight on hand can be one of your best and most easy go-to intervention tools. Try looking at something without the flashlight. And if there isn't a look or an orientation after a little processing time is allowed, try illuminating it with a flashlight, and you may see a shift of gaze and a look. Difficulty with distance viewing. This characteristic is actually a function of complexity. It's really the same thing as complexity. On the lower left side there, you're looking at a little shape sorting toy, a bright yellow shape sorting toy with a blue lid. Now, if your face is 3 inches away from that, it's the only thing you're looking at, and there's nothing else in your array to make your array complex. But if you back up 10 feet, you're looking at a very busy preschool classroom shelf with a whole lot of other toys on it. And suddenly we're looking at a much more complex array. So it's not that kids with CVI have difficulty with distance viewing because of an acuity issue. They're not nearsighted or farsighted in that way. And they're often misdiagnosed as being nearsighted or farsighted in the absence of some other, in-depth ocular exam that shows a reason for that nearsightedness or farsightedness. We often get that as a functional diagnosis because kids with CVI tend to have difficulty looking at things at a distance, but it's related to the complexity of what's around them. It's not related to how their eyes are working. Differences in visual reflexes. There's 2 primary visual reflexes: a blink to touch, a light touch in between the brow, in between your eyebrows, sort of above the bridge of your nose. That's a blink reflex that is actually achieved in neurotypical vision. It's achieved prenatally, actually. That's a prenatal reflex. I think it's at like 18 weeks gestation. So you should be born with that reflex. If you don't have that, or if it's latent or inconsistent, that's a clear sign that there's something going on different in visual processing. That may resolve over time. And then the other reflex is a blink to threat. You can try just, a hand kind of coming relatively slowly, try in different directions. And there should be a blink that happens. And in kids with CVI, it may be absent, latent, or inconsistent. We talked about visual novelty in relation to faces, but it's true for objects and environments too. Kids with CVI have an easier time looking at things that are familiar to them and that they have more experience with. So introducing new things to them, new items, new toys, it may be helpful to pair that with a similar characteristic, like a bright color, movement, light, reduced complexity, and so on, a similar feature. And finally, kids with CVI may have difficulty with visually guided reach. Visually guided reach is being able to look at, reach for, tactily interact with, and explore an item simultaneously to keeping your vision. Okay. And kids with CVI instead may look, reach, look away, or they may look away and reach, or they may just feel around for something, and once they find something, maybe they can start to orient toward it. So this is sort of a typical look away and reach, okay? The question has frequently come up, and I'm gonna just back up a second. The question has frequently come up for kids with motoric challenges. What does visually guided reach mean for those kids and who really cannot initiate reach independently? And I would strongly encourage you to think outside the box there. I have a longer article that I've written about this topic on Path to Literacy, which is a really great website in general. But I'm encouraging you to think a little bit outside the box and to understand that kids who have limited or no voluntary motor skills, we can still look at this characteristic, but it's more in the context of, can that child experience a tactile interaction, even if it's a hand under hand support or someone holding on to them or positioning them? Can they be in tactile contact and have tactile input at the same time as using their vision? Okay. Now, what we've noticed here as I wrap up is that all of these characteristics overlap, right? We're not just talking about light, we're also talking about light and color. We're not just talking about color, we're talking about color and movement. And we're not just talking about color, we're also talking about the combination of complexity and color. And so we need to be constantly thinking about how these characteristics overlap. Last little resource for you is just an observation notes section. This is just a one-pager, basically to be able to, I think the first step, if this is newer information for you, is to take what we've talked through, these characteristics, And just this 1-page chart, try to write down anything that you can observe or you have observed about your child for each characteristic. And underneath each characteristic, I've bullet pointed some little guidelines or tips, things to think about writing or observing. So just to get just to get started on breaking down, what have you actually observed? Yeah, lastly, there's just a little bit of information about the assessment stuff itself, what it's used for, and then my email. You can always feel free to reach out to me at any time. I'm putting my email in the chat box as well. And I'm going to put a link to the fact sheet in the chat box too. On that note, it is 55 past the hour exactly. So I'm going to turn it back over to you guys. And thank you so much again for having me. I hope that that was helpful and informative.
Thank you so much, Chris. I found that absolutely fascinating. There's so much information in there, and I was nodding along pretty much like this to the whole of the talk, recognizing things that were said to my son, and I'm sure a lot of the other families and people on this call have recognized similar things. And we do have a couple of questions, if you're okay, for us to ask you a few things. One of the questions which has come in, which is very interesting actually, is can you work specifically to strengthen the dorsal or the ventral stream of vision?
It's such a good question. And so everything that we're doing, all the interventions that we're doing, when we show, when we adapt things with color, light, movement, when we put it in the right visual field, basically the more experience that we're giving a child to use the vision that they have, the more, that's exactly what we're doing. We're strengthening their dorsal stream, and then we're strengthening their ventral stream. That's why it's so important to know where is your child now on this range, because we need to know if they're not integrating their ventral stream yet, the easy way to tell that is, are they making eye to object contact? If they're not making any eye to object contact yet, if all looking, 100% of looking is just this regard, this almost like looking past or through things, then we're focusing on strengthening the dorsal stream. If they're starting to make eye to object contact, or they are already making some eye to object contact, then we're strengthening the ventral stream. And the things we're presenting to them are going to be things that are more likely to strengthen the ventral stream. So the intervention is going to kind of shift, but all of these different functional approaches, the way we adapt and present materials, that's exactly what they're doing. They're strengthening those visual streams.
Okay. Interesting. And when the child is assessed for the level of CVI, so that little chart with the severe, mild and moderate, how do you have a standard kind of, I guess, thinking about tying in the ORCA measure, is there a standard that you use depending on the type of other disabilities or the other things going on with the child?
That's a great question too. No, the CVI range as it's basically a functional vision assessment protocol for getting a baseline on what visual functioning looks like. And that's where we're getting the range score from 0 to 10 and also the phase that they're in. It really shouldn't, there shouldn't be anything in there that's biased against or that in any way would conflict with all of the other functional assessment that you're doing. So what I always recommend to professionals doing functional vision assessment in general is just be absolutely sure that you incorporate all of that other holistic information about the child so that you're considering, okay, what else is going on here? Is there any statements that we're looking at in the functional vision assessment, in the CVI range, that need to be a little further explained? Like, let's say the child has an ocular issue on their right eye. Well, that's going to affect how I'm scoring visual fields. If the child is, but in no way does it look at, current level of expressive communication or anything like that. I do have other resources for those kind of things, which could be like a whole other 2 hours worth, but I created a set of guidelines for developing AAC and augmentative communication programs for kids with CVI, depending on where they fall in the range and how that combines with what their current expressive communication is like.
Okay, that's really interesting. It does tie in quite with what Christy was talking about with the measures of communication and making sure that they're sensitive to the individual child, or that certainly to the syndrome, rather than kind of a blanket approach, as we said, with a diagnosis of being blind, which isn't particularly helpful. I just wondered, do you have is there anything similar to a CVI diagnosis for in terms of hearing impairment for children?
Yeah, there is either central auditory processing disorder or auditory neuropathy spectrum disorder. And those are tricky because both are forms of auditory neurological impairment, basically auditory processing disorders. But one, I think it's CAPD. I always get the two confused in assessment. I think it's CAPD, central auditory processing disorder, that can be identified on an auditory brainstem response test, whereas auditory neuropathy spectrum disorders can only be identified on language-based hearing tests.
Okay.
But we do see a similar thing, which is it's the sensory balance issue, right? It's difficulty attending to auditory stimulus or auditory input when there's some other stimulus that takes over, like tactile, visual, positioning, kinesthetic. And also difficulty in determining which is the important sound to listen to. Like, a child who can't attend to a teacher reading at the front of the classroom because they're distracted by the sound of the air conditioner or of cars going by outside. So that's a similar type of thing related to hearing.
It's interesting because I think a lot of the SGS children have hearing impairment as well as visual impairments. But my experience was that the visual was a lot more detailed kind of diagnosis, whereas hearing, because Jude couldn't turn his head because he didn't have the motor function to be able to do that, it was a very kind of two-dimensional diagnosis and not really much was looked into further, whereas the vision, I think I felt a bit more was understood. Is that generally the case? Yeah,
that's right. And that's because audiology, there isn't much of an equivalent for a functional hearing evaluation in the way that there is for functional vision assessment. So, audiology relies a whole lot more on clinical testing. There's great clinical testing, of course, but a lot of it relies on language as an output. But there is one, I can share it for you as well, informal functional hearing evaluation, which was created by the Texas School for the Blind. I'm going to share you the link. That's a really, really good one that it should be appropriate to all kids, I hope.
That's great. Thank you.
Yeah, there you go.
Thank you. Does anybody else have any questions for Chris? If not, I will thank you again so much. That was so informative and helpful, and I'm sure many of our families will go back on and view your presentation because there's so much practical tips in there, which is what they all need. So thank you very much, Chris. Thank you all so much for attending the first day of the very first SGS Family Conference. It's been an absolute honour and a pleasure. And if I could have looked back 4 or 5 years ago and known that we would be in a position to be able to have a conference like this, I would have been astounded and incredibly pleased that we are all here talking about SGS and sharing information that will hopefully provide some hope to our families for the future with their children. Thank you again to both speakers. I mean, Christy's talk was really, really interesting and exciting, to be honest. I think we've got now a great idea as to what the ORCA project actually is. A really important survey for caregivers about our children's communication abilities, which could have a real impact on drug treatments, which could offer some improvement of the quality of life and the extension of life for our children. I think there are a lot of families in the conference who have agreed to be involved in the ORCA study, and for that we're incredibly grateful, and to Combine Brain for all the assistance with getting this project off the ground. And I hope that everybody now has a real understanding as to why it's so important. And Chris, yeah, as I said, brilliant presentation. CVI is incredibly complex, and as you said, I think we could have talked for hours and hours on the subject, and I'm sure we'll be begging you to come back to give a further presentation to some of our other families. There was great guidance there for families, and I think the resources that Chris has shared will ensure that everybody has access to those. I particularly found the information about the visual regard. I always wondered why Jude never made eye contact with me. I always tried not to take it personally, but now I understand it was to do with his dorsal and ventral stream function. So thank you so much again for all that information. So it just leaves me to say thanks again for attending, and I hope you have a lovely afternoon or evening as it is here in the UK. And I really hope that you can all join us tomorrow for day 2 of the SGS Family Conference, where we have Dr. Jessica Jewis from Children's Hospital Colorado, who will be talking about the genetics and understanding a little bit more about Schinzel-Giedion syndrome. And she will be followed by Anna Fangmeyer from Vanderbilt University, who will be outlining a really exciting study that a lot more SGS families can become involved in, the SGS disease concept study. So I really look forward to seeing you all tomorrow, and thank you ever so much.